Lisa Hornberger and her team from the University of Alberta. Dr. Hornberger is the founder and until recently the past director of the Fetal Neonatal Cardiology program and current section head of Pediatric Echocardiography. She's a professor of Pediatric Division of Cardiology and Gynecology. Lisa is known worldwide. She has around 250 publications, and she already wrote lots of chapters in books, and she is I used to be her ex-fellow and my mentor and my co-author in one of the must be bestsellers, the Perinatal Cardiology Handbook, first edition, and we are working hard on the second edition with the same team. And of course, Lisa has mentored hundreds of fellows and residents, and we're so honored to have her today. And Lisa, could you please start with the first topic of today's webinar? Also, I'd like to welcome our godfather of the series, Professor Silverman, who's been always with us and a great support to the series. And I'd like to welcome all the panelists and the speakers. Thank you. Lisa, could you go, please? Start.
Yeah, I'm going to introduce my colleague, Dr. Luke Eckersley, who's going to be presenting the first talk. I don't know if, Luke, if you could put up your slide.
Oh, okay. Sorry. I thought you were the first one, but it's okay.
Yeah, no, Luke is going to present first. It was kind of best for the flow of the topics. And Luke is presenting on optimizing fetal cardiology resource use, which is likely an important element for all programs that are performing fetal cardiology services, given the limited number of us kind of internationally. And it's important, he's also going to touch on the importance of getting to our more vulnerable patients. Luke's a good colleague of mine who works in our fetal and neonatal cardiology program at the University of Alberta, and he's shortly to be an associate professor of pediatrics. So take it away, Luke. Thank you.
Thanks, Lisa, and thanks for the opportunity to speak today. I think this is a very important topic and something that's dear to my heart. Today I'd like to cover to speak about resource use. You need to still think about what are the goals and roles of fetal cardiology practice, and then talk about what the sources of resource use really are. And then I'll talk a little bit about what the guidelines for referral are, and my own opinion, what the good, the bad, and the ugly is of those. And then I guess who, what, and when in terms of who we should be looking at for fetal cardiology and where to go from here. So what are the goals of fetal cardiology practice? Again, my own opinions and ideas, but I think it'd be fair to say that the main thing we want to do is prevent adverse outcomes. And we can do that by making sure that we're diagnosing the most at-risk cases, and those ones are things such as duct-dependent critical congenital heart disease that are going to get into big trouble after birth if the duct shuts, and also cases that are at risk during pregnancy, such as cases of arrhythmia, Ebstein's cardiomyopathy, and other such things. We also want to make sure that we're predicting cases that are at imminent risk of getting into trouble directly after birth, such as transposition of the great arteries with restrictive atrial septums, obstructed TAPVDs, and absent pulmonary valve syndrome. And Dr. Hornberger is going to be speaking more about this in her talk. And we also, of course, want to be making sure we're giving parents good information and the opportunity to make choices about their pregnancy. So to do that, we need to have accurate predictive algorithms for prognosis. We need to have good knowledge of our own local surgical data. And we want to make sure that we're diagnosing cases early enough in pregnancy to ensure that the parents do have an opportunity to make choices about whether they continue on with their pregnancies in the case of severe congenital heart disease. So we need to optimize resource use as well. And to do that, we really need to make sure that we're triaging cases to the appropriate level of care for prenatal screening and delivery. We don't want to deliver everyone at the surgical centre and waste a lot of resources in doing so. And likewise, we don't want to deliver very at-risk cases in a place where they can't be cared for appropriately. So moving on to the roles in fetal cardiology practice, I think you can probably separate them into clinical and non-clinical, and overlapping with the goals. We want to make sure that we're providing accuracy of diagnosis and counselling. We want to arrange for appropriate management of delivery. And importantly, we want to support our obstetric and radiology colleagues in providing accurate diagnosis of obstetric screening studies. From a non-clinical perspective, we have an important role in education of sonographers, other cardiologists, obstetricians, and others. We should be developing metrics for clinical service quality, such as databasing and auditing our quality of care. And we need to provide ongoing clinical research. And all of those things lead to improvements in service delivery. So what are the causes of resource use in fetal cardiology? And I guess the key question is, do the benefits of providing the service outweigh the costs? So some of the benefits that I think are well proven now. I'm not going to go through all of the sort of papers that have explored this, but there's direct benefits in terms of reducing morbidity, reduced hospital length of stay, reduced transport costs from when babies are, potentially born at another centre without a congenital heart disease diagnosis and then have to be transported. A very expensive process involving a lot of resources. And there's some reasonable evidence of improvements in neurodevelopmental outcomes from a fetal diagnosis due to the more stable infant. There's also indirect costs. So a question about whether there might be reduced mortality, and of course quality adjusted life years are impacted on the workforce in the long term. As I've mentioned, the opportunity for families to choose, and also the chance for families to really organise. So if they know that they have a fetal diagnosis, they have more time to think about how they're going to manage having a baby with congenital heart disease, including around the time of delivery. On the other hand, there's costs, and there are significant costs to providing a fetal cardiology service, including the direct costs of the service, the costs for the family to attend repeated appointments, potentially from a long way away in the case of Alberta. There's also the costs associated with screening babies that are often normal, that are felt to have a higher risk of congenital heart disease. There's a cost associated with inaccurate diagnosis, such as when we think there may be a coarctation, but that we decide we need to deliver them at a tertiary institution and they don't end up having a coarctation, a problem that plagues us all, I think. And then there's some inaccurate predictions of acuity at times, something we're improving at, but certainly a lot of resources are required to deliver a baby with all hands on deck, ECMO and surgical teams. There's also some indirect costs, and I think there's some pretty good evidence now that there is some stress to the families associated with having a fetal diagnosis and worrying about what might happen to the baby. And the family length of stay at the tertiary institution or in the town with it might be longer if they're relocated at sort of 36, 37 weeks of pregnancy and then need to stay till after an operation and recovery. Then the length of stay might end up actually being longer for the family in the tertiary town. So I'm going to talk a little bit about improvements in service delivery and guidelines for referral. Again, my own personal opinions, but things that are included in the guidelines at the moment include suspected congenital heart disease and confirmed aneuploidy, which I think are accepted to be good indications for a fetal echo, but also things like diabetes in mothers, and potentially if they have good glycemic control, then the chance of having a a positive diagnosis is quite low, and I'll show you some evidence to support that assertion. And also assisted reproductive technology in singleton pregnancies, which I think has reasonably now been shown to not be much higher than other singleton pregnancies. And family history of some conditions of congenital heart disease probably has a fairly low rate of yield. I'm also going to talk a little bit about what the barriers are to early detection of congenital heart disease. So here's some data that we recently published in the Journal of American Society of Echo, led by Clayton Boehm. So he looked at our referrals for around about a 10-year period, and there was almost 20,000 of these fetal echoes that he reviewed. And we during that period pretty much followed the ACE and AHA guidelines for referral with a few sort of tweaks. First thing to say is that there really wasn't an improvement in the yield over the 10-year period. So about 85 to 87% of the cases we saw were normal, 2 to 3% had mild or possible congenital heart disease, and then 9 to 11 had moderate to severe. And you can see that what we defined as moderate to severe up at the top there, and it's a fairly sort of broad categorization of what moderate to severe congenital heart disease might be. So what about the yield? So we had good yields from suspected congenital heart disease, which made up almost 18% of referrals. There was a 41% of cases had moderate or severe congenital heart disease. So NNE is number needed to echo on these slides. I just made that up, and it's about 2.5. So you don't need to do many fetal cardiology scans to diagnose a case of congenital heart disease if that is the reason for referral. Likewise with definite or at risk of genetic conditions. So 15 they make up a reasonably small number of referrals, but 15% had moderate or severe congenital heart disease, and you need to do almost 7 echoes to pick up a case. And lastly, extracardiac pathology. So that made up almost 30% of the referrals in this data set, and the yield was around about 6.5%. So you need to do about 15.5 echoes to pick up a case. So they're the best ones. Oh, this slide has gone crazy, sorry. So the not so good ones is maternal diabetes and family heart disease. So maternal diabetes makes up over 18% of our referrals, but only had a yield of 1.4%. So the number needed to echo, if it was the only indication, is 71. If there was multiple indications, interestingly, it did improve. And there was a 4% rate of pickup of moderate or severe congenital heart disease. So the number needed to echo is then 25. Likewise with family history, so that made up almost 18% of referrals and had a yield of 1.3, increasing to 3.4. So the number needed to echo again is 77 and then 29. So you need to do a lot of fetal echoes to pick up a case. And this is all assuming that they weren't picked up on an obstetric screening ultrasound, of course. So if you add up the cases that were picked up by having suspected congenital heart disease, extracardiac pathology, and twins as a referral reason, then that accounted for 91% of moderate to severe congenital heart disease in this study. Hot off the press, soon after that was this important study by the group from Montreal, published in Insert Cardiovascular Imaging, and they looked at all of their births in Quebec over the period shown. So that was almost 700,000 births, and of those, over 30,000 had a fetal echo. They had a more rigorous definition of severe congenital heart disease, which I'll show you. and that picked up 2.3 in 1,000 births, which is incidentally what we also found for a similar definition in a recent study. And they found that of those, 1,071 had a fetal diagnosis. So they had a pretty good fetal diagnosis rate over that period of almost 70%. But just keep in mind that that's still 30% of severe congenital heart disease that's not being diagnosed before birth. So still room to improve, even in this excellent centre. This is their definition of severe congenital heart disease. So CHD requiring intervention in the first month, or leading to mortality in the first 6 months, or leading to termination of pregnancy or intrauterine demise. Or they also defined it as congenital heart disease with a more complex morphology that they defined, anatomically, and the list is at the bottom there. So I think they're sort of accepted forms of congenital heart disease. What did they find? So overall, the number needed to echo to diagnose one case was about 28. But if you were referred for risk factors with a normal obstetric screening ultrasound, then the number needed to echo in Quebec was 250. So you'd have to do 250 echoes if they had a normal screening ultrasound to pick up one case, just based on referral for risk factors that are in the guidelines. This is a nice slide in their paper which sort of shows the breakdown. So you can see what they started with, and that they had a rate of 65.4% based on severe congenital heart disease detected at the obstetric screening ultrasound echo. And then if you added on the referrals for screening indications for risk factors, that only added 3.1% to the rate of fetal diagnosis. There's still a big chunk, like over a quarter that's missed. But the important thing, I think, for resource use is that 3.1% is all that's added by screening for risk factors in this study. Important to note also that as the rate of fetal diagnosis at obstetric ultrasound goes up, then of course the yield of screening for risk factors goes down. So you're not going to pick up as many cases the more that are diagnosed already. So it's a moving playing field, and in thinking about how we use resources in this field, that needs to be taken into account. So I guess there are still some areas for further work in developing what are the indications for fetal echo, and I know that there are new guidelines being developed currently. The question about what the yield is of multiple indications and whether those might be additive or synergistic is still largely unanswered. The risk of congenital heart disease is associated with particular non-cardiac anomalies. So differences between what the non-cardiac anomaly is and whether there may be some that have a particularly high risk and should be screened. What about limiting screening studies to cases with the highest risk, such as poor glycemic control in diabetes? And we have some unpublished data on this, which I can't show you, but we certainly see some relationship between glycemic control. What about barriers to prenatal detection? So we want to diagnose cases as early as we can to have the most options for the family, and to be able to plan and to watch babies during pregnancy. And there's barriers. The barriers to prenatal diagnosis are many, and some of them are difficult to think of ways that we might reduce because they're population factors. But there are many pressures that reduce the rates of diagnosis for that impact obstetric sonographers and the reporting of obstetric ultrasound. And one of the big ones is that they just don't have much exposure. As shown in the Dallaire study, the the rate of congenital heart disease that's severe is probably only 2.3 per 1,000 births. So if you're in a small obstetric practice, the chance of you seeing a case of congenital heart disease is low. There's also, it's also important that sonographers and reporters have education on how to diagnose this and updates to guidelines, but they're limited in the time they have available to scan. I'm all amazed that obstetric ultrasound sonographers have to look at the whole baby, and they often only have about 10 minutes to do this. At times, at least in our province, the human resources that are available to do these screening studies is limited, and particularly if you live in more rural or remote areas of our province, it is actually hard to get an obstetric ultrasound in the time frame that it is supposed to be done. And these are some of the factors that I think are limiting our rate of fetal congenital heart disease diagnosis. So just to emphasize that, there are some other factors that are sort of more socio-economic and cultural that also impact it. So if you're born remote, if you're residing in a place that's remote from tertiary care, for the reasons I outlined, financial and socioeconomic factors may play a role. And cultural factors, your knowledge of the healthcare system, how long you've been in a country for, whether you're able to speak the language in the country, all impact how you access healthcare. And some of the diagnoses are just difficult. So some of the things that we see are subtle, and we know that has a relationship to how likely it is to be diagnosed before birth. So some of the things we can do. So we can improve the guidelines. So recently the guidelines have improved from just this sort of thing, a 4-chamber view, to adding this sort of thing, which is a view of both of the outflow tracts on a sweep, and this sort of thing, which shows the 3-vessel view coming up to the 3-vessel and trachea view. So if you add all of these factors to the screening ultrasounds, then you're way more likely to pick up the more subtle forms of congenital heart disease, and we've shown this recently in a publication that's soon to be out. This is some of our data from locally, led by a master's student that Lisa and I co-supervised. And what we showed is that really all of the forms of congenital heart disease have improved from 2008 up to 2018. With some of the big improvements in the lesions that are most easily detected on outflow tract views. So within changes in the guidelines, we have seen improvements in the rates of diagnosis of tetralogy of Fallot and transposition of the great arteries, and now they're around about 70 to 80%. What else can we do? We can use algorithmic detection, and I am currently at a global AI meeting, which makes me excited about the future role for these algorithms. And in this study, led by Dr. Arnaud, and there was the senior author Anita Moon-Grady, they developed an algorithm that essentially mimics the 5 screening ultrasound views. They trained a neural network to detect the abdominal, 4-chamber, left ventricular outflow tract, 3-vessel view, and 3-vessel and trachea view, and then classified each of those as normal or abnormal, and came up with a composite diagnostic classifier, which was a weighted average of the views, essentially to decide whether the scan was overall normal. And this was published last year. So how did they go? Well, the negative predictive value of the algorithm was 100% on reasonable quality images, so it didn't misclassify much. And on the screening studies, the algorithm was as good as clinicians in sensitivity. So the algorithm picked up 88%, with clinicians 86%, and the specificity was actually better. So there was few false positives on the algorithm. So the algorithm sensitivity is 90% versus the clinicians, which was 68%. And they tested this on a range of different data sets, including fetal echocardiography images, fetal echo images from another center, and then obstetric screening studies. There was some variability between the results of the algorithm, so there's still room to move. But I think this is going to be an important part of future screening to improve our rates of fetal congenital heart disease, because some of the limitations to what sonographers can detect are not going to be easily changed, such as the rate at which they actually come across congenital heart disease, that 2.3 per 1,000 cases. What else can we do though? Well, we can provide education and support. So we need to use technology to support obstetric screening, including with central reading of cardiology images, potentially using handheld devices to overcome remoteness and hesitancy to attend, so some of those cultural factors, and providing regular in-services and on-site support potentially is something that fetal cardiology should be doing more of to increase our rates of fetal diagnosis. So just to sum up, I think, where do we go from here? Well, we need to consider refined indications for fetal echo to maximize our efficiency of resource use, looking at the recent data from our own centre and Quebec and other places. And further research is still required to identify the highest risk indications and refine who we see and how we best use those resources. I think it's going to be coming to every centre soon is going to be algorithms that incorporate on cart and incorporate it into community obstetric ultrasound that help us to detect congenital heart disease that is, don't forget, mostly in low risk pregnancies. And I think, really there is going to be an evolving role for the fetal cardiologist. Our resources potentially should be more in supporting others to detect congenital heart disease, education, and less in screening normal pregnancies. That's all I've got. Thank you.
Thank you so much, Luke. It's a very, very important talk, and it's not easy to digest. So what is the message? I mean, simply, what do you want people to know or to take away?
Yeah, I think we need to carefully consider how we use resources that are scarce, and it's important that we think carefully as a profession about the maximizing our yields, so that we're not screening a lot of normal pregnancies, but also that we're not missing cases. So how best to do that? And I think really the focus needs to be on obstetric screening ultrasounds. That we know that's where you mostly pick up congenital heart disease, and where the resources need to go. And our support as a profession, I think our support for that service is key.
Thank you. Lisa, do you want to add anything to what Luke just said?
Yeah, I mean, Luke, I would appreciate if you would talk a little bit about some of the weaknesses of the work out of Quebec, because I think it's relevant. You can't just necessarily translate the work that they've done and into every practice, but just kind of discussing what are areas that need to be improved to really be able to translate that data.
Yeah, so I think it's important to note that they have a pretty good rate of fetal diagnosis. So as I mentioned in one of my slides, there's a direct relationship between the yield of screening on risk factors and the rate of obstetric screening ultrasound pickup. And not all places have a almost 70% rate of obstetric screening ultrasound detection. So if your rate is more like 30%, then the yield of screening using risk factors goes up markedly. So So it's important to know your own local data and consider your own service in terms of what you accept referrals for and what needs a screening ultrasound. I think that would be one of the key ones. Do you have anything to add, Lisa?
I know there were things like not necessarily capturing all forms of congenital heart disease that require intervention. Some of the coarctations is an example, as well as multiple pregnancies they couldn't capture in the way they use their administrative data that they utilized. So those are things just to keep in mind. I think the biggest one though is just recognizing that translation of it really requires that your ultrasound screening is as good, if not better. But I think it was an important paper just in terms of, again, re-emphasizing we need to do better to really use our fetal cardiology resources more wisely, but not to disadvantage our patients.
Absolutely. What is the detection rate now worldwide, Lisa, and is it improving? And what do you think with what you're thinking of? I mean, is it 40? Is it 60?
I think it's very variable. It really depends on where you go. It's even very variable in Alberta. So, as Lucas mentioned, we've just finished a population study looking at who does and does not get detection. And for sure, remote patients don't get as much detection. The resources aren't as good in ultrasound screening or as available in ultrasound screening in our remote regions. And this is probably true across Canada and for many, many countries, if not all countries. And there's certainly data for that. So I think it's very variable. Do I think it's getting better? Yes, absolutely. And I suspect it's getting better everywhere, but maybe not exactly to the same extent, depending on the resources available and the screening programs that are out there.
But the catch area is the low risk, right?
Yep. Which
so
is
how
why
can we get around that? How can we get around that? Because that's not going to be cost effective.
So this was the reason we actually started to get our own baseline data to have a better sense for where we were at. And the reason that Luke actually was pursuing, not only the education, which we've been doing for years, and figuring out which of the lesions were missing and what screening views are the ones that they're not doing well with, and looking at other ways that we can look at things. I mean, TAPVC is an example because we still are picking up less than 10% in most places internationally, and looking at ways that we can do better for screening, right? But also AI. AI definitely is an area that could be really helpful if it's implemented and you do better screening, and it takes the need to have people who are really good at screening a little bit out of that equation by having more consistent screening algorithms through AI. You ultimately can bring everyone's detection rates up to where they can be, and hopefully can optimize to the best that we can get. And that would then be helpful internationally.
But also the resources are very important. We're talking about cost effective. And what you've given numbers that really, sometimes you feel, oh my God, I'm doing all those echoes, I'm getting this number. So it's a bit heartbreaking that, we have to do screening program, but, we're not getting a lot out of it. So, the government, especially we're talking worldwide now, that governments will back up such programs. And I of course, I have my heart for fetal screening, but is it cost effective? I think it's cost effective, but from the numbers you've shown, I'm not very sure if it's cost effective or not.
Yeah, there's really not a lot of data. And I think, again, it depends on a lot of factors, and it will be different in every location. For example, if you have a fairly centralized population and there's not a lot of risk of needing to transport a patient 1,000 kilometers like there is in Alberta, then that's going to affect your cost effectiveness numbers. If you have a pulse oximetry screening program or not, that's going to change your cost effectiveness numbers because of the slightly different risk, and your fetal diagnosis rate also affects your cost effectiveness of a pulse oximetry program. So there's a lot of different factors, but I think that the potential for AI to work here is really exciting. I think that putting an algorithm on an echo machine is likely to be a pretty cost-effective way of doing things, because it may alleviate the need to do a lot of screening at a tertiary level, of studies that end up being normal, and all of the costs associated with that, such as, for us, we're sometimes transporting patients from 7-8 hour drive away. Patients might drive 7-8 hours to have an echo, which turns out to be normal. So we really would prefer, obviously, not to do that. And if there's ways that we can alleviate that cost for the family, as well as the cost of doing those normal studies, then I think that's the future.
Where's the training
interim,
here?
Oh, I was going to say, in the interim, one of the things we're doing, Rima, that Luke has been really spearheading in our program is we've taken all this data that we have on our diagnostic yield for different indications for fetal echo, and slowly picking through the ones that have the lowest yields, like diabetes. So he has now done a population study that's beautiful, that gives you absolute cutoffs, number one, for hemoglobin A1C, where there's absolutely an exponential risk as you get beyond 6 or 6.1, which is sort of like the normal. Less than 6.1 is a greatly controlled. It's an exponential risk, and only looking at lesions that we can detect prenatally. Not every lesion, which a lot of studies have done, every lesion in the baby. Well, you can't see an ASD, and there are other things. So he's actually really picked it apart and even added the covariates that will now exponentially continue to increase that risk. So if we can get smart enough, for at least while we're waiting for AI to come along, to say really who are the high risk patients, really for whom we really should be doing more than just an ultrasound, and get smarter at the way we triage patients to really get the ones that are more likely at highest risk and or have more likely lesions that are going to be harder to screen.
Look, I want to thank you for this, what Lisa just said, that exponential relationship between hemoglobin A1C and the incidence of congenital heart. I believe that, but I did read the literature and said it's not a direct relationship. And I followed quite a few patients with 8 or 9, and I found no septal hypertrophy. I mean, it's not statistically significant, but this is also questionable, but we can go for that. So is this solid data that it is directly related, had a higher hemoglobin A1C is it gestational or type 1, and then the incidence of congenital heart disease? Is this a solid data?
Yeah, it's not published yet, Rima, but it's ready to go. So we're submitting it, and we feel what we did is we looked at 10 years of all of the births in Alberta, and detected and got the first trimester HbA1cs of the pre-existing diabetes and gestational diabetes. And what we found is that there was no increased risk in the gestational diabetic mums, but there was certainly an increased risk that was directly correlated with the HbA1c levels being above 6.1, and the higher they were, the higher the risk category among the pre-existing diabetics with higher HbA1c. So we feel it's pretty solid data, but yeah, I should just say it's unpublished as yet.
And
Beautiful. So congenital.
Sorry,
is it congenital heart or any congenital heart, or just septal hypertrophy?
Oh no, I should clarify, this is just for major congenital heart disease, which we define very similarly to the Dallaire paper as requiring operation in the first year of life or resulting in termination or intrauterine fetal demise. And in fact, we got exactly the same number. We got 2.3 cases per 1,000 as the base level. So I feel fairly confident that we picked up most of the cases.
I mean, the beauty is that we have access to population data, and we have only 2 central programs that do all of the fetal echo, and all pathologies get referred through those. So for terminations, we had data on those. For fetal losses, unless they never got to anyone. And then every surgical case, because we only have a single surgical center. So really solid, dense, but really interesting population data that includes, like I said, all these other covariates of the moms that have been in other studies shown to be a risk factor, but not necessarily in diabetes. So getting smarter about what we're using for algorithms for who really needs a fetal echo and who doesn't, I think is one of the ways that we can do better.
So this is another point for the guidelines. The guidelines say screening fetal echo for diabetes, not gestational, right? But we as cardiologists, I think, we screen everybody, right? So because this is what your data is showing, or did I get this wrong? Because this is the discussion goes with between MFMs and cardiologists. Which diabetics should I send you to screen? So Lisa,
So
could you please? Oh, sorry, Luke. Yeah, sorry.
We don't screen gestational diabetics, and I think our data supports that practice. And I don't think the guidelines say to screen all gestational diabetics, although they do currently say to screen diabetics who or mums with diabetes who had a diagnosis of gestational diabetes in the first trimester, because they're felt to represent a population of type 2 diabetics, because it's usually a second trimester diagnosis. Gestational diabetes is when the sugars tend to go up with gestational diabetes. So, and I think our data does support that practice. The risk is really exactly the same as the general population in the mums with gestational diabetes, but in the mums with pre-existing diabetes, including the gestational diabetics diagnosed in the first trimester, the risk is correlated with HbA1c.
Thank you so much, and we have to move. I mean, we can discuss more and get more questions at the end. And Lisa, would you be kind enough to present your next speaker, because Lisa is your group?
Absolutely. So this is Angela McBrien, and Angela is another colleague of mine from the fetal program at the University of Alberta. In fact, she is the director of the Fetal Cardiology program, and she joined us in about 2016 after spending time in the UK, and had formally trained with us, in fact. So she's going to present on the accuracy of fetal echo from the first trimester to term. One of her areas of interest is, in fact, first trimester fetal echo and fetal function. So take it away, Angela. Thank you.
Okay, thanks very much for the opportunity to present on this. I show you this slide, which demonstrates transposition of the great artery diagnosis in Alberta over the years, because there really have been major changes in fetal cardio practice in the last 2 decades. Transposition is really the perfect example to my mind. Even in my professional lifetime, it used to be just enough early on just to make this diagnosis. It was so commonly missed. However, nowadays we make this diagnosis all the time. And now we have expectations that we should be able to identify those who are at the highest risk for delivery room instability. So not just picking it out, but trying to subcategorize who's at highest risk. So I think that this talk on accuracy is completely different now than it would have been even a decade ago. And that's what makes fetal cardiology very exciting to my mind. When talking about accuracy, there are various facets of accuracy in fetal cardiology. One of which is the one that you sort of think about immediately, which is the accuracy of making an anatomical diagnosis of congenital heart disease. But to my mind, accuracy also should look towards the accuracy of our predictions for babies. How accurate are we at predicting what their physiology is going to be like? Who's likely to be stable pre and postnatally? Who's likely to run into difficulties even prenatally? And who's going to be unwell straight away after birth? Also, we spend a lot of our time counseling families, not just about the diagnosis, but also about what they can expect, including the types of surgeries or interventions their baby is going to need in the future, and also talking about long-term outcomes. We need to know how accurate we are in our predictions for our cases. In addition, I think it's really important to look at our weaknesses and highlight those. And that's not to be negative, but that's because I think it's only really through understanding our weaknesses that we can start to improve our accuracy further. So in terms, first of all, of looking at anatomical accuracy, this was a study that we produced very recently, published this year, from the University of Alberta, looking back over our experience from 2007 to 2018. We had 589 cases in whom we had both a fetal echo diagnosis of congenital heart disease and either postnatal confirmation of the anatomy or postmortem confirmation. And whenever we looked critically back through these cases, we found that we had 90% that we would have graded as an accurate fetal diagnosis. In 71% of these cases, we actually had an identical pre and postnatal diagnosis. And in 18%, we found very, very minor differences between the fetal echo findings and the postnatal or postmortem findings, which really made no difference to care or outcomes. Interestingly, of that 10% where there was an inaccurate diagnosis, we reviewed them carefully. And on review of these cases, in 45% of cases, actually looking back on the recorded images, we probably could have actually made the accurate diagnosis. So what impacted our accuracy? In this paper, we found, probably not unsurprisingly, that the type of congenital heart disease mattered in terms of accuracy. Here in this figure, you can see that our most accurate diagnoses were made in double inlet left ventricle, tricuspid atresia, tetralogy with or without pulmonary atresia, and transposition. And down here at the bottom, you can see double outlet right ventricle, truncus arteriosus, and isomerism were our Achilles heels. Those were the ones where we were less accurate with our fetal cardiology diagnosis. We found we had excluded the early fetal echoes from this experience, I should mention, and we find that later gestational age at first echo impacted accuracy. And that's probably not surprising because if you're scanning in the third trimester, there are some technical limitations to image quality. Somewhat linked in with that, we find that fewer fetal echocardiograms were also linked with less accurate diagnosis. And that probably related to the fact that we had the opportunity to amend and improve the diagnosis every time we saw a patient through the fetal cardiology clinic. In addition, we divided this up into eras, and we find that the earlier era was less accurate than the later era. So improvements perhaps with our increasing experience, and also improvements perhaps with the technology that we were dealing with. Interestingly, we find that specific training in fetal cardiology made a big difference to accuracy, rather than training in echo in general for the reading faculty. This is a hot topic area. The group from Stanford, Terry Tacey's group, also published this year on accuracy of fetal echo. And similar to us, they find that they had 11% of fetal echo errors, which had a moderate impact on clinical management. And 3% of cases had errors with a severe impact on clinical management. And very similar to us, they also looked back through their cases and found that 46% of all errors would have been detected when they looked back at their recorded images. And this speaks to human fallibility, really. And also they reference cognitive bias. So you see what you expect to see. The group in Paris published in Necker, published in 2016, and they looked at specific areas of weaknesses, which will not come as a surprise to experienced fetal cardiologists. Pulmonary veins, ventricular septal defects, and the aortic arch were the areas of challenge in their experience. Interestingly, they looked at the subgroup that went on to have termination of pregnancy, and they find that that was a subgroup where there were a lot more errors. And they find that in 9%, the postmortem gave a completely different cardiac diagnosis than the fetal echo had. And in an additional 14%, there were differences on the autopsy findings, which actually would have impacted the management. The group in Mount Sinai in New York also published recently and found 14% of discrepancies. And similar to the group in Paris, they find systemic and pulmonary veins, aortic arch, and VSDs were the areas where fetal accuracy was not as good. When looking at contributing factors, one of the major contributing factors was the complexity of the congenital heart disease that was encountered. And similar to ours, later gestational age at the first echo, fewer fetal echoes. And also they found that the level of experience of the person who conducted the first fetal echo was important. And they found that fellows doing the first fetal echo compared with sonographers had lower levels of accuracy. So that appears to count. Why does it matter? Why is it so important that we don't misdiagnose our cases? Well, there's the potential for harm even prenatally. If we overcall the congenital heart disease diagnosis, we may end up causing families to have a termination of pregnancy, which they would not have done if we'd given an accurate diagnosis. And likewise, if we undercall the severity of congenital heart disease, perhaps these families miss out on opportunities to have a termination of pregnancy, where if they had the full information, they would have taken that option. We can also do postnatal harm. If we make an inaccurate diagnosis, we can formulate an incorrect management plan. And you see this particularly in things like miscalling duct dependence, either for pulmonary or systemic blood flow. We also do harm to trust. And you can see if you make regular, frequent errors in terms of fetal cardiac diagnoses, then you will lose the trust of your colleagues that manage these cases postnatally, for example, the NICU or else your pediatric cardiology colleagues. I think one of the highlights for me whenever I think about accuracy and inaccuracy is the importance that we share any uncertainty that we have with the other teams that we work with, and also likewise with the families, so that they can understand what our level of certainty is for making their decisions for their pregnancy. We have regular meetings with our NICU colleagues and we tell them about areas where we're weak, for example, coarctation and pulmonary veins, and tell them if something doesn't smell right postnatally and is not keeping with what the fetal echo report said, to always question. Okay, so that's the depressing aspects of our weaknesses. How do we actually use this to make ourselves better? Well, one thing that we can do is we can encourage our colleagues to refer early. We know that later on first scans are less accurate. So speak with your obstetric colleagues, your radiology colleagues, your MFM colleagues, and ask them if they have suspicions to refer early. Likewise, we know multiple studies can help refine diagnosis. So this speaks to the importance of not just scanning once, but scanning many times through the pregnancy to tailor your diagnosis to being more specific. I think it's crucial for specific training for reading faculty. So we've shown that experienced fetal cardiology trained people are better than echo trained people. And so I think that we should be encouraging our reading faculty to have appropriate training to be doing this accurately. In addition, being aware of our weaknesses, so thinking about if you come across a heterotaxy or a double outlet right ventricular truncus arteriosus, being aware that those are the kinds of diagnoses that we can be inaccurate in, can change your radar and hopefully improve your level of accuracy. Personally, I don't like to trust previous reports. I'm aware of cognitive bias and I don't even trust myself. I always try my best, although I'm sure that I fail frequently, to have an open mind whenever I'm performing a repeat fetal echo to try and understand what the true diagnosis is. Likewise, I think having other eyes on your cases is really important. And whenever we come across complex cases, I'm lucky enough to work in a team that's very interested to share their knowledge and experience. And I get a lot from showing my complex cases to my colleagues and getting their opinions. Similarly, mentorship is crucial. If I find something that I don't know what I'm seeing, I'm very quick to call Lisa and ask for her help and review of cases. And similarly, when we have fetal cardiology trainees that come through, we try and keep those lines of communication open so that whenever they go off into independent practice, they're not alone and they always feel that they can share their cases with us. Quality assurance is crucial. You need to know what happens to the babies after they're born. You need to know what you miss, and you need to have a formal process for doing this. And I think it's also crucial whenever a family terminate a pregnancy on the basis of your cardiac diagnosis to really encourage them to have an autopsy to try and figure out how high quality the care that you're giving actually is. Experience is key, and there's no real way to improve your experience in years. However, as Luke has already very nicely demonstrated, low risk screening is really key. So if you can improve your low risk screening, get more cases sent to your unit, then you'll improve your experience of pathology and hopefully improve your accuracy through doing that. Thinking out of the box, think about the things that we're weak at. Coarctation, I've already mentioned. Maybe we need new approaches. There are many studies trying to improve our diagnosis of coarctation of the aorta. We have false positives and we have false negatives. It's one of the weaknesses. And the group at Evelina have been doing some interesting work looking at fetal MRI to try and improve the effectiveness of diagnosis of congenital heart disease, such as coarctation. We also know that you can develop a coarctation of the left pulmonary artery whenever the duct closes in pulmonary atresia. And our group did work looking at predictors of left pulmonary artery stenosis in this case, which can be difficult to detect pre and postnatally. And Delina Nguezi found that if the pulmonary arteries are splayed, if they're widely splayed, or if you struggle to see them in the same plane, or else if you see the duct plugging in directly to the left pulmonary artery, These are all markers for being highly suspicious for duct dependence of the left pulmonary artery. I'm going to change tack a little bit because I think that the accuracy of early fetal echo deserves separate discussion. I know that not terribly many centers do it, and I want to show you some normal fetal echoes in early gestation, just to show you the kind of level of detail you can get even as early as 10 weeks. This is an example of a normal 4-chamber view at 10 weeks. I hope you can see my pointer. So this is where the spine is, the front of the chest, the left and the right. And here we have a left ventricle and a right ventricle, and you can see the ventricular septum, and you can also see ventricular contraction. And this is a normal looking 4-chamber view, even as early as 10 weeks. If we go back to 8 weeks of gestation, then things are harder to see, but you certainly can. This is the spine of the baby, the front of the chest, and the left and the right. And here you can see the atria, which look really very generous and obvious. You can see the ventricles, which look smaller and more globular. And also, hopefully, you can appreciate that there's a rim of pericardial fluid, which we quite commonly see when we're scanning embryos at this gestational age for research. Darren Hutchinson did some work in our program looking back through our experience of early fetal echo in normal pregnancies. And this is just an example of some of the things you can see. So from 8 to 10 weeks, it tends to be in the research sphere that we're doing these early fetal echocardiograms, but really from 11 weeks onwards, we're doing them clinically as well. If you look at the blue bars, they show how commonly we can demonstrate the aortic outflow tract, and you can see how heavily in the early gestations we rely on color Doppler to actually be able to demonstrate the outflow tracts. The red bars represent the pulmonary outflow tract, but you can see that we can see these structures fairly consistently from the 11th week of gestation on, either through transabdominal or endovaginal scanning. Once again, to highlight our weaknesses, the blue bars are the demonstration of the IVC, and you can see it's hard for us to see the IVC clearly until the 11th week of gestation on 2D, and that color is our friend in terms of demonstrating this. Likewise, pulmonary veins, which are a weakness of fetal echo in general, are particularly challenging whenever we're looking at these very small fetuses until the 12th or 13th week of pregnancy, when you can start to see them a bit better. We can have a discussion about the safety of color as well, which I'm sure might come up in the panel discussion. This is an example of pathology. So this was a fetus I came across as a fellow at 11 weeks and 5 days who was referred with increased nuchal translucency. This is a 4-chamber view with left ventricle and right ventricle, left atrium, right atrium. And here you can see in the crux of the heart, there's this area of deficiency with T artifact. So this was a complete balanced AVSD. You can't see the AV valve very clearly in this plane, but we saw evidence of it being a common AV valve in the short axis. This is something the audience might be a little bit more familiar with. A fetus at 13 weeks, we're scanning through the outflow tracts. So this is spine, front of chest, left and right. And this is the aortic outflow tracts overriding a VSD and the pulmonary outflow tract coming over the top. So crossing great vessels with an overriding aorta and a smaller pulmonary artery, findings classical for tetralogy of Fallot. So it can be done, but how well can it be done? So Lindsay Allen really was a pioneer of the field of early fetal echo, and her group in London published in 2013 of a large experience, and they were reporting sensitivity of 85% with specificity of 95% by scanning below 15 weeks. They looked at 1,200 fetuses, and they had follow up in the mid-trimester of their early fetal echo findings, and they found that normality was demonstrated at early fetal echo and on follow-up study in 1,069 cases. They diagnosed congenital heart disease in 46 cases, which was confirmed at the later scan. They reported discordance in 85%, in 85 cases, which does look like quite a lot, but actually if you break this down, a lot of that was just mild AV valve regurgitation, which improved by the second scan. They overcalled congenital heart disease in 3 cases where the heart was actually normal, so reassuringly small numbers there. They felt that the congenital heart disease was more complex than it turned out to be in only 4 cases. And in 29 cases, they thought the heart was either normal or had mild congenital heart disease. And later on, they discovered congenital heart disease or else a more severe version of congenital heart disease in 29. But in only 15 cases did that have significant implications for the outcome of the baby. In terms of the weaknesses of fetal echo in pathology, Well, clearly it isn't going to be as good as mid-trimester echo in terms of sensitivity because it's harder to demonstrate things clearly. However, hopefully our experience in the group in London's will give you confidence that it's reasonably good at picking up congenital heart disease. Obviously, things that can develop over time can be missed on early fetal echo, and that includes things like tumors, valve stenosis or regurgitation, arrhythmias, cardiomyopathies, and things that you only see in the third trimester, such as ductal constriction or ductal aneurysm. Generally. Ventricular septal defects can be over and undercalled by early fetal echo, so you have to be cautious with those, as you have to be cautious with diagnosing AVSDs, which can similarly be missed. And it's acknowledged that if you have a cohort of patients in whom there's a low risk for congenital heart disease, your sensitivity will be less, whereas if your radar is set high because you have a high risk fetus, then it's going to be better. Likewise, if a fetal heart scan is done as part of an anomaly scan, that is less effective than if it's a fetal echo as a standalone scan. Moving on now to accuracy of predicting physiology or stability in the baby. Perhaps this is actually more meaningful than the actual anatomical diagnosis. The reason being because it's crucial in terms of planning appropriately for delivery, and you'll hear more from Lisa about this in the next part of the session. I'm not going to speak to predicting instability because I know you're going to hear a lot about interesting information on that in Lisa's talk. But in terms of predicting stability, the group at Children's National led the way on this. Mary D'Onofrio and her group looked at prospectively stratifying the prediction for stability, grading it as 1 to 4, with 1 being likely to be extremely stable postnatally and 4 extremely unstable. And in their categorization of the lowest risk groups, level of care 1 and level of care 2, they really had very few that needed changes in the management strategy or an urgent intervention that was not predicted. Our weaknesses in terms of predicting stability are that we can do harm if we overcall things. So if we say a lesion is duct dependent, we can do harm from prostin and its side effects. We can also do harm by unnecessarily transferring patients either to the NICU in the same hospital or transferring patients to another site for care. And that can have a major impact on the mother and baby bonding if they're physically separated during that crucial period. And I think Lisa will talk a little bit more about that as well. But we have to be careful not to overcall how sick our babies are going to be after delivery. And likewise, if we undercall it, if we miss coarctation or if we say coarctation is not severe whenever it does turn out to be, then we can potentially mismanage those patients off prostin and the babies can deteriorate even on the NICU off prostaglandin. The atrial septum is one of our Achilles heels in transposition, and Lisa's going to talk a lot about that in her talk. In terms of predicting what surgery our patients need, this was the group from Necker again, looking at 2,000, just over 2,000 prenatal diagnoses of congenital heart disease, and they had 368 discordances, of which 10% of cases had the miscall had an impact on the planned neonatal treatment, and in 7% they miscalled the long-term care strategies that the babies would need. Our group in the University of Alberta looked at this and as part of our accuracy paper, and we found only 2% having a major change in the neonatal care or outcomes that had been predicted. Likewise, in Stanford, they found 3% error that had a major clinical impact, and in Children's National, 3% with changes that significantly impacted care postnatally. I've already discussed the weaknesses whenever it comes to surgery. Left pulmonary artery stenosis is an Achilles heel, but hopefully helped by that paper we produced looking at features that can be found prenatally. The coronaries and transposition, they're just so tiny. There are some weaknesses of fetal cardiology that we probably aren't going to be able to overcome, but that should be included in counselling. We should tell people that the coronaries will be assessed postnatally and that can have an impact on risk and management. For double outlet right ventricle, that's an area of weakness, and we know that there can be difficulties in calling the relationship of the great vessels to the VSD, which can change the physiology that we're predicting. And likewise, AV valve straddle can be particularly hard to identify, and in lesions like double outlet right ventricle, that can have a major impact on the care strategy. The group in Necker looked at the inaccuracies they had in terms of predicting longer term outcome. And in almost 5% of cases, they felt that the congenital heart disease prenatally was not quite as bad as it was found to be postnatally. And in this 5% of cases, they included cases where they ended up moving to palliative care, which hadn't been planned prenatally, or what they thought was going to be a biventricular repair turned out to be a univentricular repair, or the patients needed more surgical or interventional procedures than had previously been discussed with the families, or a significant change in the complexity level. In 2.5% of cases, however, the opposite happened, and they overcalled the severity of the congenital heart disease, and the patients were suitable for biventricular repair when they thought it was going to be univentricular, or they needed fewer surgeries or interventions, or they had much less severe congenital heart disease than was thought. In terms of our accuracy, I want to spend a moment talking about the rest of the fetus. I don't want us to have keyhole vision just looking at the heart and making predictions on that. It's crucial that we try and understand what additional problems the baby may have, including genetic abnormalities and extracardiac abnormalities. And working closely hand in hand with your MFM colleagues in genetics genetics teams really is crucial to this. And another thing that I want people to know is you can't just extrapolate your postnatal experience to prenatal, because postnatally you really only see the tip of the iceberg, because you don't see the pregnancies that haven't made it to delivery, such as terminations and intrauterine deaths. I think some work that we've done that highlights this is in fetal cardiomyopathy. We published this year. And we looked at the proportion that had confirmed or strongly suspected genetic etiologies for the cardiomyopathy. And in the more recent era, we found with advanced genetic testing, we actually found an etiology in 76% of cases. 24% of our cases died before they were delivered. Had spontaneous deaths, and 26% had terminations of pregnancy. And of our live births, at follow-up at only 3 years median, we had only 63% alive. So quite different outcomes than you might expect if you diagnose cardiomyopathy in a baby or child. Likewise with double outlet right ventricle, this was our experience that we recently published. We looked at double outlet right ventricles in 99 cases and excluded those with heterotaxy. And we found a third of them had genetic diagnoses, 40% had major extracardiac abnormalities, and over half of our patients with DORP had a genetic or major extracardiac anomaly, or even both. And you can see in our experience of the genetic diagnoses that we had a lot of patients who had trisomy 13 or 18 in this prenatal experience, much more than you would see postnatally. Moving on to accuracy of predicting prenatal compromise. We know who's at risk of prenatal compromise. Ebstein's anomaly and tricuspid valve dysplasia are ones that make your heart sink because they're at high risk of developing hydrops or death in utero. As I've already demonstrated, fetuses with cardiomyopathy. Tetralogy absent pulmonary valve, perhaps underappreciated, but about 10% of these can have an unexpected intrauterine death. Complete heart block can be associated with hydrops and intrauterine death. Ductal constriction, we know, can be associated with right heart failure and hydrops. And the subset of truncus that have really significant truncal valve stenosis or regurgitation can also be at risk of developing compromise prenatally. There's been some nice work done by Jim Huda's group in Florida looking at cardiovascular profile score, and they demonstrated very nicely in an all-comers group of congenital heart disease diagnosed fetally that if you had a score of 7 or less, which is the cardiovascular profile score combines a number of features of hemodynamics to give you a general score of fetal cardiac well-being. They find if the score was less than or equal to 7, there was 88% perinatal mortality, compared with only 15% if the score was greater than 7. So now that we know that we can pick out who's at risk of developing compromise, what can we actually do to change this? And this has been an interesting focus of our research. Some people might think prenatal intervention could help, but to be honest with you, interventions are rarely actually going to help the group of patients that I've just listed in the previous slide. Medical therapies could be tried, and there is some limited evidence for digoxin in supporting fetal cardiac function. By giving it to the mom, it gets through to the fetus transplacentally. There's lots of things we can do with tachyarrhythmias, but that's a whole nother talk, and I don't have time for that today. But interestingly, thinking about delivery, we're very mindful of the fetuses that might run into problems in congenital heart disease diagnosis prenatally. So if they run into problems, we always try and think, what can we do about this? Would delivery help? If we deliver, could we change the physiology like you can, for example, in Epstein's anomaly? If we deliver, would that allow us to give this fetus a treatment postnatally that would actually change the baby's outcome? And whenever we think these thoughts, we always have to balance the risk of prematurity. And we also do this hand in hand with our colleagues from the NICU. With that in mind, we've developed a strategy for babies in those high risk, very high risk categories, that once they reach what we classify as a viable gestation, which takes into account their estimated fetal weight and their gestational age, then we start to offer them and really push for them to have very, very regular assessments of fetal well-being in order to try and catch them at the point that they start to demonstrate deterioration and would be better to be delivered. This is one example. This was a fetus with tetralogy with absent pulmonary valve syndrome. I've already mentioned there's a 10% risk of intrauterine death with this diagnosis. So we were seeing this fetus very, very frequently, and turned up one day for a routine fetal echo. And this was how the 4-chamber view of the heart looked at 36 weeks. The right ventricle had just stopped working. So very poor systolic function, markedly abnormal venous Dopplers, lots of A-wave reversal in the IVC, A-wave reversal in the ductus venosus, umbilical venous pulsations even, and also absent end diastolic flow in the umbilical artery. So this was an extremely sick fetus. We got the fetus delivered by cesarean section immediately. The baby came out with a lactate of 16, but turned around very rapidly. And I think that we salvaged a baby that would otherwise have been an intrauterine death by seeing it frequently and picking up whenever the change occurred. With this in mind, we looked at our experience of frequent surveillance, and we found 56 fetuses in that very high risk category. 18% of those had an abnormal fetal surveillance finding of the whole group. Speaking to how high risk these patients were, we divided them into frequent surveillance versus infrequent surveillance, and categorized that as echo, biophysical profile, or non-stress test at least twice a week from the point where we thought they were viable. And we corroborated in our high-risk group that a final cardiovascular profile score of 7 or less was associated with significantly higher mortality in this group of patients. So a good way to monitor these fetuses. We found a trend toward worse survival when fetal surveillance results were abnormal, suggesting that fetal surveillance can help us to effectively pick up fetuses that are at higher risk, even in this high risk group. And we also found, despite the fact that we found no difference in non-survival for the infrequent versus frequent surveillance group, you can see that the numbers were interesting. 13% died in our infrequent surveillance group compared with only 3% in our frequent surveillance group. Perhaps speaking to the fact that this is an interesting area for further research with bigger numbers. I don't have any time left, so I'll just quickly summarize. I hope I've convinced you that fetal echo is generally very accurate and well-trained hands. However, there is definitely still room for improvement. Knowledge of our weaknesses is truly key in understanding specific targets for improvement, and also the importance of being humble, avoiding overstating, knowing your program, and also using quality assurance appropriately. I think we should strive for excellence, and part of that is having an open mind, thinking about novel strategies, thinking about collaborative research, and trying to eliminate cognitive bias in our reporting. In terms of predicting prenatal compromise, we know some lesions carry high risk. Potentially for some, early delivery may actually impact outcome. And I'd like you to consider more frequent surveillance for high risk lesions once babies are viable. And I think this is certainly a ripe area for further multi-center research. And that's all I have to say.
Thank you so much, Angela. This is a beautiful talk, and it's very, very important, and I think very practical as well, that we can apply some of the important points that you said. Frequent surveillance. Now, when counseling, what do you mean by frequent surveillance? Because others would like to learn from you.
We tailor it based on how high risk we feel that the baby is from our experience and from the literature. And in some cases, it even involves admission with, Lisa would say that in her experience in San Francisco, sometimes they would do continuous heart rate monitoring for some of the higher risk babies. For us, what that it looks more like is daily non-stress tests or biophysical profiles or fetal echoes. It very much depends on how high risk you really think your fetus is. For the purposes of that research, which we presented at ISHWAG and we're in the process of writing up, we defined it as twice or more per week, having an assessment of fetal well-being through one of those methods. It's a big undertaking. It's resource heavy, and if families come from far away, for us it involves relocation of those families. It's not common for us to need to do this, but it does happen, and I think it saves lives, as demonstrated by that tetralogy absent pulmonary valve case, which was I'm not sure I was a total believer until I came across that case one Friday afternoon, and that baby would have been dead if we weren't looking at it very, very carefully. So I'm a convert. I believe it's important, and the more frequently the better, as far as I can tell, for these very high risk lesions whenever they're viable. There's no point in doing this if you've got a 25-week
can we say
TR.
Can we, Lisa, do you want to add anything?
Yeah, I mean, I was going to say Ebstein's and tricuspid valve dysplasias, I think, are one of the examples that we've done really well with. In the past, you'd have up to a 30, sometimes even higher intrauterine loss rate. And once we started saying, okay, when is this baby viable? When would we actually think about the possibility of delivery, and start doing surveillance? That's dropped to less than 10% in our practice. And it's not that we've just shifted the mortality to newborns at all, because our newborns have gotten better as well. So we've just gotten smarter by watching them. And there may be some other things that we can do along the way, and we're looking all the time for new strategies. But I think as soon as we start seeing, a non-reassuring NSTs or periods where the baby's just not behaving right, in these babies that don't tolerate little physiologic stressors sometimes, and they acutely die on you. And once they're dead, there's nothing you can do, right? Or once they've really developed a lot of hydrops. And so as a consequence, we've actually been more aggressive then. And as long as we're in agreement with our colleagues who are going to look after those babies, especially the surgical team or and others, with when we think this baby is potentially viable, when we can offer something, then we've actually done good things, bringing some of these babies out a little bit early.
So when we say, just for the sake of viewers we have different levels of viewers not doing well. So the systolic or diastolic or ductus venosus or a cardiovascular profile score, because we've learned from Dr. Huta that 7 and below is bad and a baby has to come out. Now this absent pulmonary valve, the heart was very bad. Lisa, this is for you. Would you have started treatment for heart failure? Or no, the baby has to come out?
No, so we have in the past, not for that baby. It was too acute a change, and we've been seeing that mom every week, and the venous Dopplers looked almost normal the week before, and there was an acute change. And honestly, I have been there, Rima, too many times, where either we say, we'll see them in a few more days, just make sure everything's okay, and the baby's dead, and even planning a delivery the next day. So when you see with the baby demising, by the time you're getting that baby out, by the time you're planning that delivery. And so I've seen that enough in Ebstein's, and I've seen that enough in TED absent valves. I don't trust them. Once they are doing this in a viable stage, the discussion is, this is when we fish and cut bait, is sometimes the phrase people will use. So in that situation. Having said, and I'm not sure that using DIDs in this context is going to help a baby who's now I'm not sure. I wouldn't risk it, especially in a 35, 36 weeker who you can get out and do better things for. And I think it was the right call. This baby's lactate, as Angela said, was initially 16.
Yeah.
We use DIDs where we can, especially with bad cardiomyopathies and some of those with dysfunction, especially where they're early or pre-viability, or where they're in that early viable state, but you really don't want to be delivering them at 28 or 30 weeks because your options in care and the likelihood of poor outcome is very high, and the options of care are low.
Would you give the big doses of digoxin that you give with arrhythmias, or just 250 twice a day? We're talking about treatment antenatal. I know that this case was late, but I'm just saying that sometimes you just want to buy 1 or 2 weeks And this is, I think, where our antenatal treatment can help a little bit. The score can go up to 1 or 2, not very sure. So how much digoxin would you use? And supposedly it's cardiomyopathy, and it's 31 weeks. You want to go to 33, supposedly. How much digoxin would you give?
We just would use the same dosing strategy that we would use for arrhythmia. So we would load them at 500 mics.
And you ask for the levels to be as high as 1.8 and so on.
Yeah, one to 2, certainly, because we don't really have any evidence for what level is the correct level for managing dysfunction in the fetus at this time. So we extrapolate.
I find it difficult, Lisa, to treat anybody in utero, to convince the MFM to keep the baby 1 or 2 weeks more. They don't believe in that. Most of them, they say, I want a baby out. Do you have evidence that digoxin helps? I tried to look at the literature, and I didn't find a lot of literature to convince the MFMs that, okay, let's treat, let's buy 1 or 2 weeks.
Yeah, I mean, we have handfuls that we've treated and have not gone back. And sometimes it works. I've had hydropic ASs that have responded in a positive way to DIG, where the LV function was a bit better. The RV function, which was compressed, then was filling better, and the kids' ascites get better. I've had heart blocks that so we've definitely seen it work. It doesn't work 100% of the time. No, it doesn't work 100% of the time postnatally. No. So, we'll try it if we think there's benefit and the mom is willing to try. Our MFMs are pretty good. We have really pretty frank conversations. If we feel very strongly that it's worth it for the care of the baby after birth to wait a little bit longer, they listen. If we're like, no, really, this baby is going to die, they listen. Like they're and vice versa.
They have to listen to you, otherwise there's no way out, Lisa.
No. Because honestly, I get calls where they say this is a 35-week triatresia. I'm really uncomfortable. This baby has not grown. I'll say I'd rather have a living baby out than a dead baby. And so if they are worried that you're now escalating risks and trying to get that baby out to that magical 39 weeks, it is not worth that risk. And that's what we've said with Epstein. So we talk, there's good communication, and it's a team decision.
I like what you say, Angela, very much. You said, don't believe the previous echoes. It's a bit hard to people who've done the echoes before you, but I think it's a very smart way of testing your own clinical sense, because I think this is one of the things that people would say, oh, this is a VSD tetralogy fellow follow-up. Maybe it's not. Yeah. This is a very important hint.
She can't believe mine. I tell her not to believe mine.
I don't trust myself even. So I think it's a strategy that I apply to everyone, including me. Lisa, I've never actually picked up anything Lisa's missed, but one day I will.
Oh no.
Well, we've all been her fellows, and we know what to do in the right time. Okay, Lisa, I think we have to move, and everybody is interested and waiting for you to
All right, can you hear me? So
sure.
my talk is on now the next stage is actually planning that delivery and management, and it's mostly weighted towards the worst end of the spectrum, even though the worst end of the spectrum or the sicker babies are the least common. I think that's the really important area where we can continue to get better. So as Angela's and even Luke had mentioned, planning your perinatal management starts with an accurate diagnosis, an accurate prediction of tolerance of delivery and clinical stability at birth, and as an early neonate, understanding what the family wants, I think is really important, the knowledge of services that are available at your delivery site, and a team approach. With increased prenatal detection of congenital heart disease, we've seen an increased focus on optimizing the outcomes, especially of our highest risk fetuses. But there's also been recognition that we can do better with the knowledge we have. So getting the diagnosis right and be able to predict, we now can start saying, well, you know what? Some babies aren't going to be that sick at birth. Can we de-intensify when it's safe to allow for more skin-to-skin time, which we're now learning has actual physiologic scientific benefit, not just the bonding element of it. So the spectrum of heart disease, by far the majority, I think that we tend to see and think about with respect to delivery planning are the more complex lesions that aren't duct dependent or have arrhythmias, or other fetuses with just arrhythmias. And for many of them, they won't need a neonatal intervention, but might need observation until the duct is closed, or just making sure that they're tolerating things, with occasional exceptions that we might not predict them perfectly. And then complex heart disease that are duct dependent. And again, most of those will need a neonatal intervention, but we occasionally get those ones wrong. And sometimes they actually end up being a little sicker, but most of the time not. And then it's really the exception that end up being these really high risk cases that include big time congenital heart disease. We heard about arrhythmias with high drops, or life threatening arrhythmias, cardiomyopathies with significant risk of cardiac or respiratory compromise at birth. And these are babies that obviously will require more specialized planning for care, including sometimes urgent interventions. The truth is, most of the fetuses with structural functional rhythm-related heart disease will tolerate that transition quite well. And in fact, problems in the delivery room for the majority, I would say, are more likely to be respiratory in nature, may reflect a perinatal insult or poor transition, but not necessarily specifically related to heart disease, and may even relate to overreaction with the knowledge that this baby has a critical heart problem. But certainly where there's a concern prenatally, appropriate team planning that includes the mom, the family, solid execution of those plans is really key, and that's what I'm going to lead up to. So knowing what the family wants is really important, especially with respect to delivery mode, timing, treatment, and how they're coping with things. An example is going to be if you have a very high-risk fetus that is clearly going to need something within minutes or within the first hour or something after birth, and you need to deliver at the right time and place, cesarean section may be the way we go. But for some moms, this is not acceptable, and so you respect that and have to make plans around that decision for the family. For all families, having some time with the baby is very important, and having time in the delivery room desired. But you know what? We can't always do that, and that's a discussion that we have with the families. Most families want everything done, but you have to remember the moms, I think in particular, are quite vulnerable and may feel guilty if they're not doing what is asked of them for their baby. So all of that needs to be factored into how you plan your delivery. The available services at your site are important, knowledge of the strengths and weaknesses, again, not just of the diagnoses, but also what do you have at your delivery site? Is there a need for transport for this baby by ambulance? Is it an adjoining building or same building? Is there a NICU, and if it's necessary? And at what level is that NICU, and how comfortable will they be with caring for that particular baby? Are there cardiology services, a physician or specialist, ECG echo available? And is there a cardiac interventionalist or surgical service or others that you may need to be present? Just to give you our own experience and understanding why we've gone through the algorithm that we've developed, is our biggest province-wide maternity and neonatal hospital sits here in kind of the northeast end of our city, about 6 kilometers or 3.7 miles from our surgical NICU and surgical site. And that doesn't look like it's very far, it's not a big deal, but you know, at bad times of the day, it can be a very big deal. So the best we do is about a 45 to 60 minute transit time to get the kid across at 2 a.m. in the morning. That is not necessarily true when you got big time rush hour and you're trying to cross a single bridge in that city that gives you the straightest shot to the hospital. So we have to think about that when we have babies that we think are going to be very high risk, and use the diagnosis that we have and our understanding to best make those best plans. I have to say, I love this concept of there is no I in team. This is a team approach. And I've listed all the people that we would consider are important to be involved for routine cases. And then for the higher acuity cases, we start getting our interventional team, our general and CV surgical faculty involved in decision making, and then other delivery room or surgical staff. So we do have a really solid team approach, and we are evolving better and better to find lines of communication, which is also key to make that team efficient and work well to lead to better outcomes for our babies. So Angela had mentioned these categories of care. I think this is very helpful at sort of providing some basic sense of what are we likely to see for these babies. We are now testing this with some additional subcategories. These have been modified in our American Heart guidelines, but were initiated by Mary D'Onofrio and her work at DC Children's. So it starts with palliative, and I'm going to run through these individually with case examples. So certainly palliative care is part of our team's work, and as a team again, in making sure if there is pathology that we consider lethal or with high risk of mortality pre or postnatally, or those associated with long-term severe disability and morbidity. Those are lesions that we would consider offering palliation. It requires preparation of family, details of the course of events, planned well ahead of time for the family and the care team. Even the care team in your higher acuity center may feel uncomfortable or need guidance as to what the families actually want. And having that planned ahead of time is most important in making sure things go down the way the family wants and what's best for the baby. So consider where, when, and how to deliver and what supportive services are available. And for some, delivery in a local hospital where the families can be close by with their other family members is actually really important. So, but most of ours, we choose, most of the families will choose active perinatal treatment. And so now we're going to think, where are we going to deliver? And most of these will be at a tertiary care facility near us. When are we going to deliver? And the gestational age for most are going to be aiming for that 39 weeks or above. Usually we do ours between 39 and 40 weeks. We'll have an induction if they haven't delivered by their by 39 weeks. We plan an induction for most between 39 and 40 weeks. For most, it doesn't matter when you deliver in the time of day or how they're delivering necessarily, but how they deliver may be important, separate from obstetrical indications, if that baby's going to get into trouble with a delivery, if you think this is a hydropic baby who might not tolerate labor, or if you really have to have that baby in the right place in the right time, a cesarean section may be also something that you consider, but fortunately that's less commonly necessary. And then finally, you obviously have to plan postnatal management. As Angela had mentioned, we do a lot around, we have a fetus at risk for compromise for either hydrops or sudden death, and most of these are in the mid to third trimester, or late mid to third trimester. And we start talking already early at what gestational age is the baby going to be viable and a go for baby. That will dictate how much surveillance we do, and when you can provide support or treatment options. And that's also involving the discussion with our surgical team and the rest of our program. We consider risks to the mom or other babies in a multiple gestation pregnancy, which is an increasing issue that we face. And that can be very challenging in chorionic and monoamniotic pregnancies in particular. We consider, will the baby's circulation tolerate the stresses of labor, delivery, and perinatal transition? And would the baby have otherwise presented? How would that baby have presented had a diagnosis not been made prenatally? Using that, we've ended up de-intensifying in babies that we think would have otherwise presented in 2 weeks of age with a murmur, so that there's time for skin-to-skin contact and bonding. And now we know there's a lot of science behind this that we're going to learn more and more about in the coming years, that the babies are physiologically more stable, even really extreme prems, given short periods of skin-to-skin from the moment they're born with that mother or with the father or with a parent. So category 1A we would consider are the lowest risks. These are the simple defects that could even deliver at a local institution, like an AV septal defect, and we have plans for follow-up for those babies with cardiology. We include some more complex lesions as 1B, and these are defects that don't have a predicted risk of instability. An example would be a triatresia with mild pulmonary outflow obstruction. They usually don't get into trouble. They're not dropping their pulmonary vascular resistance usually within the first 24, 48 hours. So you have some time to allow mums to be with the baby and to de-intensify. So these are usually the non-duct dependent lesions, the TETs, the TET dwarfs, the dwarfs with normally related great vessels, no outflow obstruction or mild outflow obstruction, single ventricles with mild to moderate PS we throw in there as well, or those that have no obstruction, as long as there's no other factor that might add to their risk. One thing of note, it may be difficult to predict the severity of pulmonary outflow obstruction in some of these, and some of these are at high risk for extra cardiac pathology you may or may not diagnose before birth. So those are factors that need to be, we will deliver them in our tertiary care center and monitor them, but we don't transfer them to the surgical center. We want to make sure moms and babies are able to stay as much together as possible. This is a simple double outlet right ventricle with no outflow obstruction and normally related great vessels, and this baby is going to present as a large ventriculoseptal defect, which of course doesn't usually get babies into trouble in the first 24 hours. Category 2A are the more higher acuity babies, but they're still usually pretty stable. They have minimal risk of instability in the delivery room, but require, say, neonatal cath, specialized imaging, surgery, and or monitoring while the duct closes. And these are the non-duct dependent lesions like a truncus arteriosus, but they can get into trouble sometimes. Of course, not those with the interrupted arch. TET MAPCAs are a unique part. Sometimes it's hard to know for sure that they're not duct dependent, so we tend to be a little bit more cautious, we'll still keep these babies on the side of the river with the mom, but do echoes very early. And if there's question, we bring them over because we want to make sure that we're not missing a duct-dependent circulation. Coarctation, where severity has not been declared, we actually will try to keep them on the side with the moms and allow the duct to start closing, but leave the baby watched on the NICU very closely. So this is just an example of a truncus. So just giving you some idea. 2Bs are the ones that are duct dependent. These are the simpler ones. I also would consider the 1B or 2A that don't behave the way they should in the delivery room as ones that then go to category 2B. And these are babies that would be started on prostaglandins and transferred to our surgical site. Having said that, if the baby is stable in the delivery room, we've really pushed, most of these babies don't acutely fall apart. And if they're behaving well, let mom have a little time, let the parents have a little time to spend with the baby before that transfer, because you're going to take that mom and baby and separate the mom and baby, which isn't ideal for the baby and it isn't ideal for the mom. But that's sort of what we have to do when we have more services on the other side of the river 24/7. And then we make sure that moms are and the families are getting to be with the baby as much as possible prior to surgery. Category 3 are babies that can have some risk, but usually we think they're probably not going to fall apart or have issues. An example would be a transposition where, and this is obviously a transposition here, where the atrial septum doesn't look too bad. You've got this nice flappy septum primum, and the flow comes up, and you see a nice big flow orifice there through the fossa ovalis. And this is a baby we think is going to be okay. Are we perfect at predicting that? No way. So at least knowing this is a lesion that sometimes these babies fool us, our team already knows when those moms come in labor, they're already making sure that the team that's on service on the other side of the river, the team that's on service on the maternal unit is recognizing this baby could be sicker than we anticipate. And so they're already prepared just in case. Tachy and bradyarrhythmias would be an example as well. And cardiomyopathies, particularly without hydrops. We've now been able to safely deliver most of these at the Royal Alex at the maternity unit and then transfer the babies across. But we have everything prepared just in case they misbehave, and most of these are induced at 39 weeks. So the categories 4 and 5 are the sicker babies, the babies that have a higher risk of being unstable or needing an intervention right away once there's placental separation. Examples, of course, are hypoplastic transpositions with restrictive atrial septum, obstructed total veins, heart block with a low rate, especially with decreased function in hydrops, and the really bad Ebsines are examples. We would consider in our situation, because we can't do vaginal deliveries in our surgical site where we really would have these babies deliver, we do a cesarean section. Unfortunately, right at this point, that's right now the only choice we have. Of course, if you're in a place that the baby can be induced and delivered in your surgical area or in your surgical center and access to care is immediate, then that's maybe the way you go. But they're harder to do, and when you're trying to plan timing and have the whole team around and the team that's necessary, I think for us the cesarean sections made the best difference. So, but these are fully planned. And finally, category 5 are those babies with congenital heart disease that we do prenatal listing. We prenatally listed a handful of babies in the last 10 to 12 years and only had one actually get a heart before the baby was actually delivered. But we also have a fully planned course of events and have an algorithm of treatment. For these babies, typically we won't offer them a heart before 34, 35 weeks and before they're about 2.5 kilograms, but we have a whole algorithm planned for this. It's just a really horrible LV aneurysm in the 3rd trimester that we were offering this, that it kind of blew out in that 3rd trimester. So 3 primary categories we think about are those with low cardiac output, respiratory compromise, and hypoxia. And obviously, some of our babies have all 3. And these are the highest risk. Angela and I think Luke had also mentioned a whole listing of lesions that we think about, lesions that we've worked with. Not all of them would be delivered in our surgical center. It's only where we think they're at the highest risk. And I've listed all the ones that we've done and been involved with. Now, this looks really busy. I'm not going to go through it. We actually have a really well-organized algorithm that's been recently updated with additional experience of who we keep at the Alex, where the moms are going to stay and recover, who are those that are duct dependent that we really need to transfer, but we think are going to be stable in the delivery room, that we give moms a better time with the baby, and then really who needs a surgical OR delivery over in our Stollery Children's Hospital. And this is where we have the algorithms that we go through with these really high-risk babies. So what we do with these babies, this is our algorithm for when we're going to deliver a baby. When the cardiologist is very anxious, the fetal cardiologist anxious that this lesion is likely to result in this baby falling apart at birth or requiring an intervention like a transposition, intact ventricular septum with a restrictive atrial septum, we actually have a discussion with the moms to make sure that they'd be willing to do a cesarean section, and then with the MFM team to make sure that the mom is safe to have a section over in our surgical unit where there is not a lot of obstetrical services. So we want to make sure mom is healthy enough to do this. And if any of those answers are no, we deliver at the Alex, but the case is still presented to our surgical conference so everyone is aware that that baby is coming. And as soon as mom hits the door in labor or they're being induced, everyone is aware so that we know we might have to scoop and run to get the kitty across. If the families agree and the MFMs agree, yes, we can move forward. The case is discussed with our newborn specialty team and then presented at our surgical unit again for everyone's buy-in. And part of it is that we have to use OR cases, OR spaces to do these deliveries. And so we want to make sure the surgeons are in agreement and need to make sure our ICU folks, our neonatal colleagues, and everyone else is. And once we say yes, there's a whole cascade of communication, of notifications, of making sure the right players are there, and identifying point people on each of the teams that are going to be involved with the care of these babies. We have a couple meetings, one as a care team and one with the family to make sure everyone is clear on what is to be expected, and also what plan A is, B, C, when to transition care in the delivery room, the operating room, and the patient's information is even added to our surgical list. Then on the day of delivery, so all our consents are well in place. The day prior to delivery, mom's admitted to the women's hospital and transported over the first thing in the morning as a day surgery patient. And she arrives in our OR, the whole team is there. We introduce ourselves. We have a team huddle to say, what is our game plan? This is this patient, and this is what we're expecting. This is plan A, B, and C. Baby is delivered, and whatever happens, happens, and then the mom has to go back to the obstetrical center in 3 to 4 hours. So this is sort of what we do for our highest acuity cases, and we actually even are working on consistent debriefs for these. So finally, we've had 40 cases since basically 2011, most since 2013. And the larger numbers are the transpositions and hypoplasmids. You can see a spattering of other lesions that we have felt was appropriate for a delivery in our OR because of the risk of needing ECMO, of instability, of respiratory difficulties, of being profoundly hypoxemic and needing an intervention, et cetera. Just an example of a bad critical AS. This one had the ascites, did get somewhat better with DIDs, but still had ascites, and the RV function wasn't perfect. The baby's atrial septum also looked quite bowing, and there wasn't a lot of flow across it, and the baby's cardiac output was not fantastic. So we actually delivered this one. It was an earlier case, and this is the team. What you're seeing is a very bowing atrial septum and very little atrial LA egress, and the LV function was terrible. This baby went for an aortic valvuloplasty within 45 minutes because he wasn't very well, and within a week was off prostaglandins, doing quite well. We've had cardiac tumors compressing the uncomplicated, or the side that's sort of unaffected ventricle. This is a big cardiac tumor in the right ventricle, compressing the left ventricle and causing critical pulmonary outflow obstruction. This baby was also delivered, had an acute draining with ultrasound guidance of the cyst, reducing the size of the tumor and allowing that left heart to function within minutes of delivery. And then the baby, who was quite stable, went for a tumor debulking the following day. This was a terrible one we had over Christmas last year. This was a total veins with a really bizarre confluence that looked like it was in the heart. I thought it was a core, but either way, I was very worried that the pulmonary vein flow was very abnormal. It was a big right pleural effusion, and thought this baby would come out profoundly blue with basically pulmonary vein obstruction. She delivered going into labor at 32, 33 weeks, fortunately on Boxing Day, and delivered. She was brought over promptly to be delivered actually in our OR. Baby was delivered, profoundly blue, and put on bypass basically within 15 minutes. Underwent a TA-PVC repair, and the baby's about 4 months or so, 5 months now of age. But an example of a very sick baby. And this is the most common. We're transposition with intact septum and restrictive atrial septum. We look for a small hole, thickened atrial septum with very restrictive leaflet movement, high velocity ASD flow, and ductal constriction. So that's a thick atrial septum and a small hole. This is actually, IVC's here, and that atrial septum should be way over here bowing, and it's not moving very much at all. And in fact, this baby with the small ASD had an almost not visible ASD after birth and got the septostomy done within about 20 minutes. Was quite sick. We've had 16 such cases that we identified as category 4, 46 others in the same period as category 3. How did we do? 11 actually made it to the OR. The others actually delivered early. Of the 11 making it to the OR, 8 needed emergent BAS. Interestingly enough, we had one with an ASD of less than 2 millimeters that got out to 6 hours, one with an ASD of 4 to 5 millimeters that got out to 8 hours, and then one that had a really difficult atrial septum. They ended up doing an early arterial switch, and one that they couldn't do it because the atrial septum was intact, and the baby went on to an emergent ASO arterial switch. There were 5 others that ended up being delivered earlier than we expected. All 5 needed septostomies, and we use a cutoff of less than or equal to 2 because that's 2 hours, because that's where we can safely get the kids across. One, in fact, arrested on arrival to the stallary before that atrial septostomy was done, and these are babies that are pretty blue in their preductal SATs, as well as having small ASDs that we've just gone ahead and done the septostomies, not waited till some of them we've not waited until they've been acidotic, as you sort of lose that advantage. Of the 46 that we ended up delivering at the Alex, in fact, 6 of those 46 did need an emergent BAS at less than or equal to 2 hours and made it across to have it done in our stallary site. But 40 didn't, 9 requiring a BS within the first few days. So that leaves us with a sensitivity of almost 70%. This is prospective data, so it's not perfect. Specificity of 93%, positive predictive value of 80%, and negative of 87%. It's of note, again, that all of the ones ultimately either needed an early arterial switch or an early septostomy of those that we predicted. The hypoplast were the others. We had only 7 that were considered category 4 in the same period, 5 delivered to the Mazankowski in our stallary OR, 3 requiring an immediate intervention, 2 needing ECMO to have that done. 1 had a BAS at 6 hours, and 1 had a NORAD at 36 hours for a very, very complex atrial septum. Felt difficult to go after, but the baby was getting quite blue. There were 2 that delivered elsewhere. 1 very last minute decided they'd want palliation. This baby died within minutes of delivery. And 1 absolutely refused from outside of the country, refused a cesarean section, delivered at our maternal hospital, ended up on ECMO on arrival to our program, and was in such extremis that the family and we thought that we should be discontinuing care at 24 hours. So how did we do? 46 total in the same period, in that whole period. 7 predicted to need BAS or stenting, 5 required an intervention at less than or equal to 2 hours, whereas 2 did not. And of 39 predicted not to require intervention, 39 did not require an intervention prior, particularly less than or equal to 2 hours. And just of note, those that delivered outside, we had no survivors versus 80% where we delivered them in our OR with a sensitivity of about 100%, specificity of 95%, positive predictive value of 71%, and negative predictive value of 100%. We're looking for a small ASD. We do that to and fro flow profile in the pulmonary vein, or a VTI of forward versus reverse over the reverse flow ratio of less than or equal to 3. Really been useful in predicting those babies, and this is just a baby with a very high gradient who was quite blue. So we use specific features that we've been quite successful with. So what about the rest of our cases? I'm not going to go through all the individual ones, but when we looked at those needing an urgent intervention of less than or equal to 2 hours, about 52.5% required something, ECMO or a surgical intervention in that first 2 hours. It doesn't assess the risk of how sick these babies were and what transport would do, mind you. The positive predictive value of fetal echo for an endpoint of intervention of less than 2 hours. Again, ECMO for a few of them, surgery for others. As a surrogate of how critical these were, of all the cases, it was 70%. For transposition cases, it was 100%, and for hypoplast, 86%. This is just an example of a very massive mediastinal tumor in a 33-week fetus that acutely enlarged, with the baby having very poor output and evolving hydrops, who had a successful tumor resection within a couple hours delivery. So in summary, detailed definition and prediction of clinical presentation are critical for counseling and critical for planning of perinatal care. Clarifying the family's desires, needs, defining strengths and limitations of your program, and decision-making as a team are also really important for planning your management. Current strategies include more aggressive measures of care for fetal heart disease, which may be associated with acute compromise at birth, with need for immediate medical and or surgical intervention, which are clearly the minority of diagnoses. They can also include de-intensifying care for even more complex pathology when it's safe to improve the family experience and increasing that beneficial skin-to-skin time. So with that, I will thank you very much.
Thank you so much, Lisa. And thank you for coming despite not being well. Really, we're so grateful. And so, I mean, listening to what you said. So, what is the message? It's very well-based data. So, should we all follow this category scheme? Do people already in centers follow that? Is this part of the general practice or center-based?
I think that the categories is not bad. As long as it's provided to, or it provides communication to the care team on the other side of what they are to anticipate. And we'll tell them the strengths and weaknesses, as Angela said. There's a lot of discussion around that and the uncertainty. Where we are certain they really fit that category 1, and we're currently reviewing our experience there, but I can tell you the vast majority of patients we have been correct with, and those babies have done well. So, using the categorization, you kind of can anticipate. You have category 1, we don't anticipate a problem. Category 2, on the other hand, they can sometimes get into trouble, or there may be things that we have missed. The example are the tetralogy with MAPAs. Category 3 are those that kind of be planned just in case those babies come out sicker because they are a higher risk group. So I think using that, it's not bad. I think it's also helpful, as well as Mary had done, Dr. D'Onofrio had done, in going back and looking at how well you've categorized those cases and how often you were wrong for your own team, but in general in fetal cardiology. So I think that's actually, they're very, very useful.
So I mean, I think it's beautiful, and people who would like to go back to the category paper, it's in circulation, I think 214.
And I think that hopefully we'll be doing some revision, a little bit of revisions and fine tuning on the subcategorizations that may be helpful as well.
Great. And I just want to ask you a question that Angela put on about where we miss. And the septum was part of the categories where people miss the diagnosis. Why is that? And where exactly, from your expertise, the septum could be?
So you're talking about the atrial septum and transpositions. Part of it is that the time you really need to look is after 35 weeks, because that's when they're most likely to be small. And as we all know, and as also already discussed, that's also the toughest time for us to image. You're looking at 35 to 40 week moms, mostly 35 to 38, 39 weeks. You're trying to see them. I actually bring them back a couple of times because at some point I'm most likely to get one image that I can be absolutely convinced one way or the other there's a problem. So that's the number one problem. They're not the easiest to see, although we're getting better. And the more prenatally diagnosed transpositions we've had, the better we've gotten at this. We've just gotten better. The ductal constrictions are a lot less common. They were in 4 of like 16 of our cases, so only a quarter. So the ductal constrictions are 100% ones that you need to be really leery of, irrespective of what you see at atrial septum. The other issue is that, and as demonstrated in the one case, we had a 2 millimeter ASD, which any cardiologist would say that's not going to be enough for the kids to mix. So you're predicting that this 2 millimeter ASD is not going to be enough, and you're seeing it beautifully, and somehow the kid can get out of several hours before getting a septostomy. So there is some window of stability that some of these babies have. It's sort of almost a little honeymoon period that for some reason they mix, and whether it has to do with still having some of the circulating oxygenated hemoglobin, who knows? But a lot of our colleagues in the field have said the same thing. They've been surprised with some that they're certain the atrial septum is really restrictive. And then the kids come out and they have 20, 30, 60, 130 minutes or longer to work with. But some of them don't. And, we had one kitty who really shocked everyone, who came out. They couldn't do an atrial septostomy. The atrial septum was completely closed. I couldn't tell that prenatally for love or money in this mom. And the kid crashed onto bypass to have an arterial switch. So now we have plan A, B, and C. Is that B going to be ECMO? stabilize the baby and then do the septostomy, get the kid off ECMO and send the kid to the OR, So we're now better fine-tuning that. But I think part of it is that part of it is you can't rely on pulmonary vein Dopplers because you don't have high LI pressures like you do in a hypoplast. So there are other physiologic measures that aren't quite the same and aren't quite so easy. We're going to learn more. The Fetal Heart Society is still in the midst of a prospective study with many transpositions and with intact ventricular septum. We're looking at specific parameters that I think will be very helpful and hopefully being presented in the coming months.
So going back to what you said, because we'd like to learn from you. Now, simply the message is that if you have a transposition with intact septum, bring them often to follow up. Don't trust your PFO measurements or foraminal value measurements. This is one message, but the other thing that you've shown that you've taken the ratio of the foraminal value to the septum, and then you've done the flow and the Doppler. So the message could be as well, don't trust just the 2D, do the measurements, do the flow, and think back and sit and bring them back again. Is this correct?
Yeah, and mostly, so I used to not do this. I went to a meeting in Japan in like 2013, 2014, and colleagues in Japan were seeing a lot of these moms more than once after 35 weeks. And once we started doing that, and coupled with the fact that we're seeing a much more prenatal detection of this disease, we started getting much better at identifying the highest risk babies. So 35 weeks, we see them. We see them. Obviously, prior to that, we always look at the atrial septum and the duct, but often where they start having more visible restriction and the duct is visibly not normal is even later. So we will bring them back at 35 weeks and reassess everything and make a decision 35 weeks, 36 weeks as to whether or not it's a higher risk that we would deliver in our surgical OR.
An important message is that people who see transpositions as referrals and you're sure of the anatomy, don't sit back and relax. Ask them to come back at 35 weeks, right?
Yes,
because
absolutely.
What you're saying about the stages now, sometimes you do an echo and you never see them back again. So, what we have to learn is that bring them back if you're not sure. It's better than asking the MFM at whatever hospital to look at that. There's no harm in bringing the patient again, is it?
No, I think that having another look at these in the late third trimester is really key. We've made some decisions literally within 48 hours to have mom delivering the baby in the OR, where we finally got really clear images of the atrial septum that really was concerning, and the kids came out quite blue. So, we're getting more experience here. The majority of them we're getting right. We're still fine-tuning that. We'll have more data to come. But if you think about this, in my mind, these are the babies that we really need to do everything we can. These are babies who have good outcomes otherwise, generally. They're otherwise healthy babies. And the worst insult they have is what happens before they go to surgery at the time of delivery. The bluer they are, and also even the mortality is higher pre-operatively with something like a 6% mortality, and that mortality includes loss because of a restrictive atrial septum, and it includes loss in babies who were prenatally diagnosed. We learned that the hard way back in the 90s. So, being aggressive with these particular cases where you have a good chance of doing really good things with the knowledge that you have prenatally is where we need to go.
But also, this is very important you are referring this. You have everything in your center. I know it's a very good center, but we're talking about worldwide. In such a case, you need an ECMO. So not all cardiac centers have ECMOs worldwide, right? So this is also very important in planning if there's restriction. Going back to one more question with the restriction of the ductus, this is very important. So you said severe ductal restriction. Is this induced by medication or what? Tell us more about that and how could be a pitfall in the diagnosis and management here.
So these are in transpositions?
No, from where you can detection rate was low. What Angela showed, one is the septum, and one of them is the restriction in the ductus, severe ductal restriction. Did I get this right, or I got this wrong? Angela.
Yeah. I think she has. She may have peeled off because she's in clinic.
Mm.
I think she was mostly talking about, misdiagnosis or not being able to predict those that are necessarily duct dependent, and making sure that the way in which you care for those babies accommodates a potential weakness, that you can be observing them while the duct is closed, and or making sure that if they need prostaglandins that they're on prostaglandins.
Okay, so this is in the context of ductal dependent circulation. You follow babies looking at the flow. We're not talking about acute ductal constriction induced by medication and riboflavins and so on.
No.
Okay, that's a different thing. Yeah. Okay, great. I think I'm the only one who's asking you because I enjoy that. I'd like to thank you again and again, and I'd like to thank our audience. And I just want to say you can watch the whole series on Congenital Heart Academy on the YouTube Fetal series. We are having like thousands and thousands joining us all the time on the YouTube. May I thank Luke and Angela and Lisa and Dr. Silverman. I'd like also to thank our angels for the Congenital Heart Academy, Sasha Agati, the surgeon who does the recording and does everything, and he's the founder or co-founder of Congenital Heart Academy, and Grace Van Leuven and Gil as well. So thank you again, and see you in 5 weeks with another topic. Thank you, and bye-bye.
Thank you so much for having us.
Well, thank you, guys. You did a magnificent job. I've been listening attentively to you. I hope you feel better, Lisa. I felt sorry for you with the looking for a glass of water when you were coughing like that. But
yeah, I know. My apologies.
It was a great session, and it's a great blueprint for everybody that's interested in fetal cardiology as to how a program ought to be run. And you deserve all the kudos for that. And it was so delightful to see the rest of your group.
Yeah, it's actually very good in planning and learning. This is a session focused on beyond fetal cardiology services. You are trying to be at a higher category and trying to serve more at a higher level. So thank you again, and hopefully Lisa will meet on the Zoom soon if your time allows.
I hear you.
Absolutely. Thank you.
All right.
Thank you.
Thank you,
Have a
everybody.
good night. Have a good
Bye,
day.
everyone.
Bye-bye, everybody.
Ciao, Sasha.